Okay, Assalamu alaikum. So today we will discuss about the assisted reproductive technique, and that is the talk article overview of the assisted reproductive technology. So assisted reproductive technology (ART) include all the treatment and the technique that encompass the in vitro handling of the human gametes or the embryo with the intentions of the achieving the pregnancy. The birth rate is the 21.4% and the embryo transfer rate is the 33% with ICSI. Okay, so what are the steps of the assisted reproductive technique? First of all, we will give the pre-treatment adjuvant strategies, and then we will down-regulate the pituitary gland by using the long protocol and the short protocol. We discuss it later. And then the third step is the control ovarian hyperstimulations and the fine follicular maturation trigger, oocyte and the sperm retrievals in the embryology process, monitoring of the embryos with the help of the ultrasound, intrauterine embryo transfers, and then at the end we will give the luteal phase support with the progesterone at least 8 weeks. Okay, so in the diagram you can see that first of all you will give the ovarian stimulation by the clomiphene citrate or any other method by the GnRH agonist or antagonistic. After that, you will monitoring the follicles with the help of the ultrasound when there is a follicular growth, and then you will see that there is a egg retrieval with the help of the, it is also the ultrasound guidance. And after that you will aspirate the follicles and there is the egg. It is the healthy egg. It is covered by the zona pellucida. Then you will fertilize the egg. Here you see there is the fertilizations, and then at the sometime you will use the day 3 embryo when there is a not when the egg are not good quality and you are not sure about that it can it can progress up to the day 5. So in this case you can transfer the day 3 embryo. Otherwise, if there is a if you are sure that the egg are very good and they mature, and then you will transfer the day 5 embryo at the stage of the blastocyst. Okay, so here you see that the embryo transfer. Okay, so this start from the talk article. You can see when there is a hydrosalpinx, then before the IVF you will do the salpingectomy first. Okay, so it improves the fertilization rate and the pregnancy rate. In the uterine septums you will do the hysteroscopic septoplasty before the any ART method using. Okay, in the case of the intramural fibroid, if the intramural fibroid is less than the 5 centimeter, then there is a no need to remove. Okay, so if it is more than the 5 centimeter, then you will remove the intramural fibroid by the myomectomy. Because if it is a less than the 5 centimeter, then it does not distorted the cavity, or it is not by doing the myomectomy does not improve the rate of the pregnancy. So in this case you will not do the myomectomy. Okay, submucosal fibroid you will do the myomectomy and improve the pregnancy rate. Okay, another case is the subserosal fibroid. There is a no in need of the do the myomectomy or any type of the surgery because there is a no need, no increased rate of the success in the treatment of the ART. So you will keep on the conservative management. In the polyp you will do the polypectomy. Intrauterine adhesions you will do the radiolysis, and superficial endometriosis you will do the laparoscopic treatment. Deep infiltrating endometriosis, the surgery for the symptoms relief only. Okay, because there is a no need of the surgery in the deep infiltrating endometriosis. But if their patient having the complaint of the pain, so you will do the surgery. Otherwise there is a surgery is not done for the fertility treatment. Endometrioma you will not do the surgery if the endometrioma is less than the 4 centimeter. Okay, so these are the main points. Recurrent endometriosis surgery for the symptomatic relief, not for the treatment of the IVF. Okay, so this chart is important. After that, there is the now we will discuss about the steps of the IVF. First of all, we will do the pituitary down regulation. We already know that we will use the two pathway, either the agonist by using the GnRH agonist, that is the long protocol, and by using the antagonist, that is the short protocol. We already know that the long protocol is used on in those patients in which there is the no any normal response of the ovary. When there is a normal response of the ovary, then you will use the agonist pathway. In the high response and in the low response of the ovary, you will choose the antagonistic pathway. Okay, so what are the agonist and the antagonist? You will only remember their name. So agonist, all the agonists have the lin, lean, in their end, and all the antagonists have the lex in the end. Okay, so in this way you will remember the name. Okay, you just see it. That is the long protocol, and it is start from the previous cycle of the day 21. We will give the GnRH, and we will give the gonadotropin at day 1 of the cycle. GnRH short flare protocol, in which we will start the cycle in not from the previous cycle, in the day 2 of the current cycle, and at the day 3 we will give the gonadotropin. In this way you will remember all these GnRH ultra short protocol, and GnRH antagonistic fixed protocol, and GnRH antagonistic flexible protocol, and the GnRH antagonistic single bolus. Okay, after that you will do the HCG shot at the day 15. Okay, after the 35 to 36 hour of the HCG, then you will do the endometrial thickness. Okay, you will do the endometrial thickness 2 to 5 days after the HCG. Then you will after taking the endometrial thickness, when it is a more than the 5 millimeter, then you will transfer the embryo, and once you transfer the embryo, then you will give the luteal felt support. Okay, okay, so after the pituitary down regulation, then you will do the control ovarian stimulation. You will monitor by the ultrasound. GnRH agonist protocol, baseline scan. When you will do the ultrasound scan, you will do the baseline scan before giving the FSH stimulation. You will do the ultrasound. Then second scan after 1 week starting the FSH. Okay. Then the final scan is within the 12 to 36 hour of the planned trigger. Okay, so in the agonist protocol, you must done the 3 scans. You remember it? Okay, so we already discussed that in which or ovarian response you will use the which protocol. So the chart is showing that when there is the MH and the antral follicular count is the high, then it means there is the ovarian high response. In this case you will not use the agonist pathway because there is increased risk of the OHSS, so in this case you will use the antagonistic pathway. But when there is a normal ovarian response, then you will use the agonist pathway. In the case of the low ovarian response, when the MH and the how will you know about that the ovarian response is the low and the high? By testing the FSC antral follicular count and the AMH. Okay, so when there is a low response, then you will go for the antagonistic pathway. Okay, so in this picture you will see there is the egg retrieval. You can see the egg, the 2-cell embryo and the 4-cell embryo, 8-cell morula, then early blastocyst and then the extant blastocyst. So sometime they will ask about the day 3 cell contain the how much, day 3 embryo contain the how much cell. So it contain the 8 cell, and when you transfer the blastocyst, so it contain the, sorry, I think so it contain the 60 cell. It is okay, so it contain the 64 cell. Okay, so we will check, we already discussed that we will check that there is a good quality blastocyst, then we will transfer the embryo at the blastocyst stage. Okay, the customary practice of the embryo transfer has been either on the day 2 and the 3 of the ultrasound guided transvaginal oocyte retrieval, when the embryo or the 2 to 8 cells are the cleavage stage, or in the blastocyst stage. So mostly we will transfer at the blastocyst stage, and we will transfer the one embryo to reduce the risk of the multiple birth. Okay, in this picture you will see the embryo freezing. We already discussed that we will freeze the embryo when we will give the patient, when we will give the treatment for the cancerous disease, and in which there is the iatrogenic infertility. So in this case we will freeze the embryo. So you can see that they will freeze the embryo in the nitro oxide. Complications of the assisted reproductive technique. What are the complications that it is associated with the treatment, the side effect of the drugs, and the ovarian hyperinsulination syndrome? Risk associated with the sedation and the anesthetic, and risk associated with the oocyte retrieval, hemorrhage and the infection, surgical sperm recovery risk and infections, bleeding, testicular atrophy. Okay, associated with the outcome, we already know that the IVF has increased risk of the multiple pregnancy, ectopic pregnancy and the heteropic pregnancy, and the congenital anomalies in the children. Okay, in the woman there is a small little increase the risk of the borderline ovarian tumor, and in the childhood there is increased risk of the childhood cancer. Complication of the assisted reproductive technique. If the patient have the younger age and have the low body mass index, and having the polycystic ovary disease, and history of the OHSS, all increase risk of the OHSS. If we will give the treatment of the IVF, and she has a already history of the OHSS, and the patient having the polycystic ovarian disease, so in these cases the OHSS risk is further increased. Okay, the late OHSs occur 10 or the more days after the HCG trigger, and it is generally precipitated by the effect of the endogenous HCG from an early pregnancy. Okay, so late OHSs occur after 10 days of the HCG trigger. Okay, the risk of the multiple pregnancy almost 10 times higher with the assisted reproductive technique than the spontaneous conception. That is also MCQs. Data from the human fertilization and embryology report that the multiple birth rate is the 24%. The chance of the woman become the pregnant within the monozygotic identical twin, including the monochronic, monoamniotic, appear to be the higher with the single embryo transfers, that is the 0.7 to 3.1, then in the natural conception that is the 0.4. The blastocyst, agar hum the blastocyst transfer and the intracytoplasmic sperm injections are the associated with the increased risk of the monozygotic twin following the single set of the embryo transfer compared to the cleavage stage and in the IVF respectively. ओके मतलब ब्लास्टोसिस्ट में, और अगर हम उसके ब्लास्टोसिस्ट स्टेज पे हम अगर एम्ब्रियो ट्रांसफ़र करते हैं, ठीक है, और एक सी कर रहे हैं, तो उसमें इंसिडेंस ज़्यादा है मोनोजाइगोटिक ट्विन का, ठीक है, एज़ कम्पेयर टू दी क्लीवेज स्टेज, उसमें कम है. The overall aim of this policy was to reduce the national birth rate to meet the target of the 10%, ठीक है. Okay, what are the risks of the ectopic pregnancy and the heteropic pregnancy? The prevalence of the ectopic pregnancy in the women undergoing the assisted reproductive treatment ranges between the 2.1 and 8.6. Background risk is the 1 to 2% following the natural conception. The incidence of the heteropic pregnancy is 1 in 30,000 in the general population, which increases to the 8 in 1,000 following the ART treatment. These all percentage are very important. Okay, the complications after the egg retrieval is the vaginal bleeding, that is the 1.4 to 18.4%, pelvic infection, that is a 0.1 to 0.6%, and really with the severe intra-abdominal bleeding, that is the 0.05 to 0.2%. Okay, factor affecting the treatment outcome, we already discussed that that is the female age and the previous obstetric history, and the body mass index and the lifestyle ovarian reservoir marker, the number of oocyte retrieval and the fertilization method, embryo quality, and the number of the embryo transfers, and the male factor. So all these are have the important role to the success of the ART. Okay, cervical by using the assisted reproductive technology, there is no any increased risk of the cervical cancer, no overall increased risk of the breast cancer, the possibly small increase of the risk under the age of the 25 years. The ovarian cancer, the no increased risk of the female factor infertility, possible the increased risk of the borderline ovarian tumor. There is no increased risk of the endometrial cancer. Okay, so you all know that there is increased risk of the breast cancer and the borderline ovarian tumor, small increased risk in these cancer, but there is no effect of the ART on the cervical cancer and the endometrial cancer. Okay, so Human Fertilization and the Embryology Authority rating for the intervention commonly employed in the UK practice to improve the success of the assisted reproductive treatment. Intervention for which there is a growing body of the promising evidence, but the further research is still required. इस पे मतलब अभी तक रिसर्च हो रही है, ठीक है. एंडोमेट्रियल स्क्रेच अगर हम करें, मे बेनिफिट द वुमेन विद 2 और द मोर प्रीवियस ART फेलियर, ठीक है. तो अगर उसमें हम करें तो फिर बेनिफिट हो सकता है. हाइलुरोनिक एसिड. Okay, so the moderate equality evidence suggests the improved pregnancy rate and the live birth rate, and egg activations with the calcium ionophore early result are the promising, but evidence is needed. Intervention for which there is no available evidence to show that add-on is effective and safe. The reproductive immunology, the risk attached to the treatment, some very serious. Okay, so that's all about the two talks we will discuss. One is the overview of the ART and other is the complications of the ART.